sclera. So it's a pool of blood trapped between the conjunctiva and the sclera. So it looks terrible, but it's no big deal. The body will reabsorb the blood, and there's no treatment for it. Okay, look on page 29. And a lot of y'all have already been on trips. This is not really relevant, but this is just some ideas I suggest if you've never been on a trip. Proper preparation for the trip is essential for a successful trip. You need to carry everything you need with you. You usually cannot get things that you really need after you leave the U.S. Get your passport well in advance. Number one there is just basically go with somebody that knows what they're doing. There's 1,000 details on a medical mission trip. And I don't even know what they all are because I always go with a group that takes care of everything. But just make sure that the person that's leading the group takes care of all the details, because you don't want to go to a third world country and they've forgotten to get transportation, or they've forgotten to get interpreters or something critical like that. So just make sure that they know what they're doing. Number two, it'd be good to recruit a helper to act as your optician. The glasses are often too big or too small. You know, out in the villages in India, the typical Indian woman weighs 80 pounds, and the typical Indian man weighs 120 pounds. So they need all children's glasses. And so that's obviously not available, so you often are having to put, relatively speaking, huge frames on a small person. So have the person that's going to be the optician go to their local eye doctor and get some training on how to adjust glasses. And because if the glasses don't fit properly, the value of the glasses is going to be greatly reduced. So get somebody on the team to go get some training and let them be the optician on the trip. Okay? Number three, you need to be as self-contained as possible. Try to take duplicates of critical items in case one gets lost, broken, or stolen. You don't want the trip to fail because one critical item is lost or broken. I found that instruments are really difficult for patients to understand, not very reliable. I'm convinced that the subjective technique I'm going to teach y'all is a pretty good system. Number four, basically mark out number four, because I don't do that anymore. I did suggest carrying the glasses in these plastic trunks you get at Walmart, but now we're having more and more of an issue with having to pay tariff on taking used glasses in. So you really don't want, those trunks are a red flag. They want to know what's in them. So put your glasses in just a regular suitcase and carry them in. Don't use something that's going to just make them, you know, so try to get them in. Don't create an issue. Because you know you don't want to get in an argument with the folks at the airport. So just try to get out of the airport as quickly as possible without raising any questions. Number five, take twice as many glasses as the number of patients you expect to examine. As I said, if you're going to see a bunch of patients, 20,000 patients, I think that the 70% plus 20 to 25% minus rule would be valid. But if you're going to see a smaller number of patients, you can't really predict what you're going to need. But if you take twice as many glasses, then I think you'll be pretty safe. You need about 75% plus, and plus corrects what? Presbyopia and hyperopia. And about 20 to 25% minus, and that will correct myopia. And then some Plano sunglasses and some eye meds. Down at the bottom of page 30 shows you a graph of kind of the distribution of glasses that you'll need. Flatten the graph out. As you can see, I've got it real high in the very low powers. I don't really do that anymore. As you can see there, I've got really high and then come down. So the 0.50, you need a lot of, well, 0.50, I've got you need a lot, and then it's a pretty stable from 1 to 3. I don't give out nearly as many 0.50s as I used to. I think if somebody refracts 0.50, they basically just want free glasses, because 0.50 is not very strong at all. So if they refract 0.50, unless I have a good reason to do so, I don't prescribe it for them. I tell them their eyes are fine, they don't need glasses. The rest of the chart is pretty accurate. The vast majority of the glasses you're going to need are between 1 and 3. Above 3, the demand drops off dramatically. Stamina, try to get some exercise before you go, especially if you're dealing with jet lag. If you can get into decent physical condition, you'll have a much easier time on the trip. Examining more than 100 patients a day can be very physically and emotionally exhausting. Take some duct tape with you. You'll find all sorts of good reasons for that. The examination kit, back in the back, I've got a list of things that I suggest you use, and I put them all together here in a little kit that I can provide to you if you want it, but you can get most of these things on your own, so you don't really need to get it from me, but I've got it available if you want it. The refraction kit, the flippers are what I'm calling the refraction kit. Okay, clinic setup. Let's talk about it, then I will read about it. What I suggest you do is set it up similar to this, with the examiner on one side, the patient here, and your interpreter knee to knee with you. What I use for a distance visual acuity chart is another human being's eyes. Some folks use, visual acuity charts and all this sort of stuff. That really doesn't make any difference. What you're trying to do is get the patient to see as good as you can with the glasses that you've got. The human eye has enough detail to provide an excellent distance visual acuity chart target if you tell the patient to look at his eyes. So make sure your interpreter understands that that's a big deal. Don't say look at him, don't say look at his face, say look at his eyes. Okay? Now, the near visual acuity chart, come up with something that's culturally relevant. If the patient can read, obviously a Bible in their language would be fine. If they can't read, come up with something that they can relate to. Remember I told you the story about the lady in India wanting reading glasses for rocks in the rice? So I came up with a near acuity chart, rocks in the rice. If the patient's complaint, if the guy in Kenya's complaint was, I can't see the thread of needle, so I've got a needle and thread. So come up with something that let's pass that around, something that they can relate to, that meets their needs. Now sometimes people ask, my glasses are a little scratched, can we still use them on a mission trip? And my response is, if they're any better than these, then they'll probably be fine. A lady wore those into a clinic in Kenya. And a man wore these into a clinic in Macedonia. And so, we say, well, how can they wear glasses like that? Well, it's all they got. So they're better than nothing, so they keep wearing them. Okay? Okay. So look on page 32, clinic setup. So you arrive at your clinic site, which will usually be a building, a church, a school, a meeting hall, a shed or a tree or someplace. When you arrive at the site, quickly evaluate the site and decide how to set up the clinic for maximum efficiency, good patient flow, good crowd control, enough room for eye clinic, optical, and counseling. Maximum efficiency, we've already discussed how you have a limited number of clinic hours, so you want to be as efficient as possible. Good patient flow, you must decide how the patient will enter the clinic, enter the clinic area, get the exam form filled out, go to the eye clinic, optical, counseling, and exit the area. Good crowd control. In some countries, if you lose crowd control, you'll be forced to close the clinic. You must decide who will be responsible for guarding the door and allow patients to enter in an orderly manner. This is totally depends on the culture. In some cultures, they'll stand in line for hours and not move unless you tell them to. In other cultures, they just get pretty wild pretty quick.
You want to have another patient ready to immediately sit in the exam chair when the current patient is given the filled out exam form and sent to optical or counseling. You must not allow so many patients to enter that chaos develops. And finally, enough room for eye clinic, optical counseling, and medical clinic if you have one. You must decide how to allocate the available room for maximum efficiency in an orderly clinic. I'll diagram a sample clinic setup if you have a rectangular room. If the area configuration is different, set up a clinic based on your needs. So page 33 kind of gives you an idea of how I suggest you set it up for a joint medical eye clinic. Number one is a door guard. Number two is if you have enough people, somebody inside that looks at the exam form, verifies the chief complaint, and sends them to medical or the eye clinic. Number three is the eye clinic eye exam waiting area. Number four is your interpreter. Number five is the patient. 6 is the examiner. 7 is some sort of table or stool or something to hold your refraction kit. 8 is something close by that you've got your medications in if you have any. Number 9 is your visual acuity chart. And what is your distance visual acuity chart? Somebody's eyes, right. Because remember, it doesn't really matter if you get the patient seeing 20/20 or 20/40 or 20/80. You just get them seeing as good as you can, and you stop. So it doesn't really matter what the actual visual acuity is.
What's the distance they should be out?
At least 10 feet. Usually you're in a confined area, so 10 to 12 feet is about the best you can normally do. But if you get them that far out, that's close enough. Number 3, we got that. Number 10 is the optical area. It's where you have your glasses. So the patient will come in, go to the eye clinic waiting area, go to the exam area, get their eyes examined. The examiner will fill out the exam form and write 3 things. What 3 things will he write on the exam form? Plus or minus, near or distance, and dioptric power, right. So plus 2.00 N or minus 3.00 D, right? Okay. Then give it to the patient. They go to the optical area. The optical folks will get the glasses and adjust them as best they can, send them to the counseling waiting area. 12 is the counseling, and 13 is out the door. Okay. Look at the look, a couple, y'all can read about all this. Look at number 9. Number 9, remember, is your human distance visual acuity chart. Ask a national to sit about 10 feet away and face the patient. If the chief complaint is poor distance vision, ask the patient to look at his eyes and tell you which is more clear, either choice 1 or choice 2. Be sure the interpreter tells the patient to look at his eyes. A patient in any culture can relate to looking at another person's eyes. 10.
Looking for in his eyes.
Nothing. Just look at his eyes and tell me which is more clear, choice 1 or choice 2. Which one of these 2 choices makes his eyes more clear? Okay. 10 is the optical area. You'll have the boxes of glasses lined up by power so the optical person can quickly and efficiently get the proper prescription, or you can use the shoe rack that they use. Just come up with something that you're comfortable with. It'd be very good if the optical person can get some training at his hometown eye clinic on how to adjust glasses. The frame very well might be too big or too little, so getting a good adjustment can be a major challenge, and any training would be helpful. You may need several people to work in the optical. It'd be good to have only one national helping in the optical. I've seen situations where several nationals were helping in the optical. One of their friends came in. They started trying on every frame available to find the perfect frame. And that might take a half an hour to do that. And meanwhile, you've got a big line of folks waiting to get into the optical area. When you're trying to see about 30 patients an hour, this can be a major bottleneck. And I've also seen cases where the helpers started helping themselves to sunglasses and cases and things. If the counselors are busy, ask the patient to wait in the waiting area until one of the counselors can see them. 12 is the counseling area. Each counselor will have an interpreter, talk to the patient about his spiritual condition and to pray with him. I like to give the counselor a free gift to give to the patient. I usually give the counselors the pens and let them give them to the patient. At the end of the clinic, the counselors will tally the forms and give them to the local Christian leader, the pastor or missionary for follow-up. It's very important you follow up on this and make sure the local Christian leader understands that he is responsible for following up on each patient that came through the clinic. The follow-up is the key to the success of the clinic. If good follow-up is not done, the spiritual value of the clinic will be greatly reduced. So that's a big deal. Make sure somebody's willing to do that. Now, we got another philosophical issue that you're going to have to make a decision on. I have always tried to do it this way, where the patient gets the eye exam, goes to optical, and gets their glasses. And my argument for doing that is, one, if they've already got their glasses, then they know that the glasses are not a bribe. And two, the counselor can use the glasses as a great object lesson of the grace of God. The glasses were free, but you had to accept them. Just like the grace of God is free, but you have to accept it. In India this year, the local Christians said, we want you to do the counseling before they get their glasses. And their reason was, if they get their glasses first, they might try to just skip out, not go to the counseling at all. And if they get their glasses first, they'll be so excited about getting the glasses, they won't really listen to the counseling. So what I'm doing now is I'm going to defer to the local Christian leaders. Let them make that decision. I still think glasses first is better, but I'm going to give the two options to the local Christian leaders and let them make that call, because they know their people better than anybody. Okay, look on page 36, which is just another copy of page 33, in which I basically do a flow chart where the patient comes in, goes to the eye clinic waiting area, to the exam area, then to optical, counseling waiting area, counseling and out the door. Or if they don't get glasses, they come in, eye waiting area, get their eyes examined, go straight to the counseling waiting area, the counseling, and then out the door. Look on page 37, the eye examination form. Everybody's got copies of the form, right? We've already been over this one time, but I'll quickly review. Giving you copies of the examination form. It'll follow the patient through the clinic, be given to the local Christian leader at the end of the clinic. The examination form has the following functions: get the patient's name and address, get the patient's chief complaint. And is everybody comfortable with that, with the chief complaint idea? Yes. What their number one problem is. Okay. It gives you a way to convey to the optical the prescription that's needed. And what three things do you write on the form? N or D, positive or negative, dioptric power. D, it allows the spiritual counselors to record the results of the counseling to again allow local Christians to do a more effective follow-up. And put number E. What's the other thing we talked about? Anybody remember what the last thing is? Yes, sir.
The two different methods?
No. Another great function of the exam form. Follow-up. No, one other. I've got that down here. What's another thing we haven't talked about? Excuse me? No. No. It allows you to wait a way to close the clinic in an orderly manner. So write that down. Number E is give out enough forms for the number of patients you're going to see, and make sure you don't give out too many forms. And hopefully, after you've seen all the patients that have forms, you can close the clinic and go home. There's no angry patients out there. Okay? So don't dare give out too many patients. Don't dare give out too many examination forms. Make sure you see every patient that gets an exam form. Okay? Find a local Christian that speaks the language and can fill out the form, the name, address, and everything, and chief complaint. So when they come into the exam room, that part should be filled out. And then have your interpreter verify the chief complaint, and then you do the exam, and write the prescription, send them to optical, counseling, and out the door. And then the counselor, or the last person that sees the patient, keeps the exam form. So if you do counseling and then optical, then the optical person will keep the exam form. If you do optical, then counseling, then the counselor will keep the exam form. Okay? Everybody good on that? Okay. Okay, page 37, down toward the bottom, the gross eye exam. When the patient sits down, look at the exam form and determine the chief complaint. If the chief complaint is poor visual acuity, you do a brief gross exam with the pen light. Look for redness of the bulbar conjunctiva, which is the part that covers the white of the eye. Pull the lid down and look for redness and swelling of the palpebral conjunctiva. Hold the pen light at about a 90-degree angle to the cornea and look for corneal scarring. If the complaint is refractive, poor distance vision or poor near vision, I do a very cursory evaluation. If the complaint is redness with discharge or something other than refractive, I do a much more thorough evaluation of the eye. Okay. But if if a healthy 45-year-old sits down, his eyes are white and bright and clear, and he says, "I'm having trouble reading the Bible," I hardly do anything, but I just go straight to refraction then, because I'm 99% sure that he needs some reading glasses. Okay, number 3, cataracts. Hold the light to the side and move it slowly to the edge of the pupil to evaluate the lens. So hold it at about a 45-degree angle and come in, and right when the light beam crosses from the iris to the pupil, look for a white reflex. If you see a white reflex, then you know that you have a what? Cataract. If the pupil is jet black, then you know one of two things. What two things? What two possibilities? No cataract. What's the other possibility? They've had cataract surgery. Okay. If there's no white reflex, you know the light is going straight to the back of the eye. Nothing is reflecting back out. So either the lens is clear or the lens is missing, one or the other. Okay. So hold it about a 45-degree angle, come in, and right where the light beam crosses from the pupil, from the iris to the pupil, look for a white reflex. If there's no white reflex, then the patient either does not have a cataract or has already had cataract surgery. If the pupil is black, then the lens is clear. If you see a white reflex, the patient has a cataract, and the whiter the reflex, the denser the cataract. Cornea, if the chief complaint is eye pain, take a lot more time to evaluate the cornea, look for corneal ulcer or abrasion. If you see any corneal opacity, you need to stain the cornea with fluorescent and evaluate with a blue light. That's what we've done here on this picture down here. Put sodium fluorescent in, shine the blue light, and you can tell if the epithelium is intact. What are the two layers of the cornea that we're concerned about? The outer layer, the epithelium, and the stroma. What's the big deal? Stroma scars, epithelium clear. Exactly. So if you see that there's something going on with the cornea, and you stain the cornea, and there's no staining, the greenish color is uniform everywhere, then what do you know? No, there is a scar. The epithelium is healed back over, so there's no corneal abrasion. So there's a scar in the stroma, an old scar that you can't do anything about. And so that's the way to determine if you got a fresh injury or an old scar. So if there's no staining, then you have a corneal scar that you can't do anything about. If there is staining, then give them an antibiotic. Okay? So if the chief complaint's eye pain, take much more time. If you see any corneal opacity, stain the cornea. If there's any corneal staining, give the patient an antibiotic. I've got 6 times a day. Change it to 4 times a day. 4 times a day is plenty for 5 to 7 days. If the staining's at 12 o'clock, which is at the very top of the cornea, You need to avert the lid and look for a foreign body under the lid, and I'll show you how to do that later. The conjunctiva, if the complaint is redness and discharge, the presumptive diagnosis is conjunctivitis. Conjunctiva will be red with a colored discharge. Give about antibiotic 4 times a day for about 7 days. If the complaint is redness with itching, the presumptive diagnosis is allergic conjunctivitis. Give tears or an antihistamine or Benadryl, which Benadryl is an antihistamine, an oral antihistamine or a topical antihistamine. Okay, now we're going to go over the refraction technique. So what do we say black was? Positive. What's red? Negative. And what are the numbers? Diopters, right. Okay. Now you do exactly the same thing every single time. When I moved to Denver 32 years ago, they were building a nuclear power plant. And I got to know some of the nuclear engineers that were designing that plant. And they told me something I never forgot. And the plant's called McGuire Nuclear Station. And they told me that they designed that plant with one concept in mind that I never forgot, and I have used that same concept with this seminar. They said, we designed that plant to be designed by geniuses to be used by idiots. I said, okay, that's a good idea. So don't worry about a thing, y'all can do this. Okay? Okay, hold your hand out like this. You have your interpreter.